So let's switch over now and see how we handle one of the most dreaded emergencies that we get in our hospitals, and that is diagnosis of acute myocardial infarction. Dr. Soni asked me to just look a little bit more into the depths of how we can localize from the ECG a myocardial infarction as to where exactly the block is. I can understand as an interventionist, my perspective is a little bit different from the perspective of a physician, but it's very important for all of us sitting here that when we deal with a patient with acute myocardial infarction, we kind of prognosticate these patients, because that's what is going to determine how best we are going to manage our patient. And I would say, just as has been emphasized over this morning since the beginning, the clinical history, of course, is of paramount importance. And I would say here, just a simple look at the heart rate of the patient. Even before you see and dissect out the ECG, if I have to say what's the most simplistic form in which you will diagnose or prognosticate a patient is heart rate. Patients who have very fast heart rates with large anterior infarcts, it does indicate that your patient has significant hemodynamic load and you are dealing with a high-risk patient. Similarly, patient saturation, oxygen saturation. Phillips classification we've all been taught. Phillips class 1, 2, 3, 4. Phillips class 1 is low heart failure, 2 is mild heart failure, some crepitations at the bases. Phillips class 3 is crepitations beyond the mid-chest, and Phillips class 4 is patient in cardiogenic shock. Mortality ranges from 5% in Phillips class 1 to 15% in Phillips class 2 to 30% in Phillips class 3 and 60% in Phillips class 4. So just a good clinical look at the auscultation of the chest is going to give you a very significant kind of parameter as to how your patient's prognosis is going to be. But what we are going to do in the next 15-20 minutes is we will see as to how we will look at the electrocardiograms, and of course it's a useful piece of information. It tells us about the electrical activity of the heart, and which reflects on in terms of how the myocardial dysfunction in your patient with acute myocardial infarction is, which will subsequently depend upon what complications your patient has and what average mortality of a myocardial infarction even today is 7 to 8%. Even in this era when we have very effective thrombolytic agents, we have primary PCI by our way, still mortality of acute myocardial infarction happens to be 7 to 8%. So we are dealing with an issue which is quite significant. If we look at the electrocardiogram, within few seconds changes start coming up in the T waves. You have these tall T waves coming up, and then secondly the changes come up in the ST segment. Still more few minutes or hours, the changes come up in the QRS complex, and over days you know the ST remains up and then the ST starts coming down. So this is what we all look at an electrocardiogram. When we find the initial part, there is a tall tented T wave, then the ST segment goes up, it gets kind of hooked up as if it's looking up, and then the terminal part of the QRS complex also gets affected. So as ischemia progresses from early time to a more significant grade of ischemia, the ST segment from the T wave, the ST gets involved, and then the QRS complex also gets involved. Mind you, we all know 15 to 20% infarcts, especially in diabetics, especially in elderly individuals, infarcts are painless infarcts. So very often these get missed, and we looked at many years back at what percentage of patients were getting thrombolized with us. Not more than 25 to 30% at that time were getting thrombolized. The CREATE study, which is the largest study from this country of 20,000 individuals of STEMI and non-STEMI across our country, 170 centers. Some centers in Ludhiana also participated. 55% of patients get thrombolized in our country, and 6 to 7% patients get primary PCI. So there is a significant larger proportion of patients who are getting thrombolized, and of course the reason is patients are coming late, there are some logistic problems, there are some cost issues, we are diagnosing late, but also there is a segment of patients, about 8 to 10%, in whom the electrocardiogram does not show up. as the criteria for giving thrombolysis, you all know, is ST elevation in more than 2 leads. Thrombolysis has no role to play in patients who do not have ST elevation. You might document on echo, whatever criteria, but the WHO guidelines, the ACC/AHA guidelines suggest unless you have ST elevation in more than 2 leads, do not thrombolyze your patients because we do not have data in this subset of patients. So initial ECG may not be showing you abnormalities that you are looking for. As you will do, that's the reason we have a role of serial ECGs. And of course, you should keep in mind pseudo-infarct pattern. Patients with acute pericarditis, do auscultate your patients when they come. Patients with hypertrophic cardiomyopathy, patients with electrolyte imbalances could be having diffuse STP changes, which you might misdiagnose as an infarct. We used to be all taught that the number of leads, and this impression we also get from the GISI and the ISIS data, that more the number of leads showing ST changes, probably we are dealing with a bigger infarct, patient has a larger infarct. But this doesn't hold when we today realize that there is a poor correlation in patients with infarct between either the number of leads with ST and the subtotal of ST elevation, something that we used to be taught, and people used to do CPK and the levels serially. So these are not conventional simplistic things which are going to help us in terms of seeing what the infarct size is. I bring you back to the axis plotting of what we routinely do for looking at the axis of the electrocardiogram. And we know the lead 1 is pointing towards the left, the AVF points towards down, the lead 3 points towards the right and down, and lead 2 points towards the left and down. So if you have just this simplistic, what we always say, if both are positive, axis is normal, if the AVF is negative, axis is left axis, if lead 1 is positive, axis is right axis. So that is for the axis of the QRS complex. So I'll request you to switch your mind from the QRS axis to the ST segment, because we are going to look at the ST segment in the next 10-15 minutes to look at what is the location of block in your patient of myocardial infarction, and so thus estimate that 3 patients who come to you in the emergency with ST elevation in V1 to V4, they have arterial wall infarction diagnosed, which ones are bad prognostic patients, which ones are better prognostic, so that you can segregate these patients and maybe decide upon yourself, I'm going to thrombolyze this patient, I'm going to thrombolyze this patient with a more effective thrombolytic agent, or maybe I'm going to send this patient for a primary PCI. So it's going to help you as physicians also. We know the inferior or the basal surface of the heart is supplied by the right coronary artery more often than by the circumflex, and an inferior infarct presents with ST changes, Q waves in 2-3 AVF, septal V1, V2, anterior V3, V4, lateral infarcts V5, V6, and we know this is the vessel supply, the right coronary artery, the left anterior descending, and the circumflex. RCA supplies the base of the heart, LAD supplies the septum at the anterior through its diagonals, and the circumflex supplies the lateral wall, and when it's a left dominant circulation in about 40% patients, it might supply even the basal part of the septum, part of the back of the septum. So this is essentially, we have 3 coronaries and we have infarcts, which could be anterior infarct, inferior infarcts, or lateral wall infarcts. So let's see how we are going to look at anterior wall infarcts, the infarcts which are larger infarcts, which carry more worse prognosis. Now, if a patient comes to you with complete heart block, and patient has an anterior wall infarct, that's a separate segment. It's a trifascicular block, it's a block at a lower level. Mortality in this patient is going to be something like 60 to 65%. If you have a patient complete heart block with inferior wall infarction, it's a block which is an AV block, increased vagal tone, mortality is not going to be more than 10 to 12%. So anterior infarct, wide QRS complexes, in complete heart block is a very bad prognosis. I would not recommend you to keep this patient if you are in a nursing home. You must send him, because a large percentage of these patients are ultimately going to kind of have a bad prognosis. Now, the accuracy of ECG depends upon previous infarcts if your patient has had, which artery is dominant, any CABG or left bundle branch. New onset left bundle branch block itself is a criteria for thrombolyzing patients. So if you have earlier ECGs, you have a new LVBP, besides ST elevation, it's a parameter in which you should thrombolyze your patients. Now, we all know the left anterior descending is a branch of the left main coronary artery. It gives these septal vessels and it gives these diagonals. The septals are more important because the septals supply the septum, and septum is the most important part of the ventricle. And septum is the one which determines what prognosis your patient is going So the first septal supplies the basal part of the interventricular septal, the base, the beginning, including the right bundle branch. So just keep this fact in mind. It's the S1, the first septal, just as the LAD emerges from the left vein and which divides into the circumflex and the left anterior descending. The first septal, the part which is proximal to that, that's what we call as the proximal LAD, and that is what we carry. Most studies where interventions have been done, where PCIs are done, CABG, it's the proximal LAD story. Wherever the proximal LAD is involved, you will be impacting mortality, whether you talk of chronic stable angina, whether you talk of unstable. So it's the proximal LAD which should be in your back of your mind to diagnose and not miss because it carries a worse prognosis, because it involves the whole of the septum in that case. The D1 supplies the high lateral region of the heart, because we know the diagonals, they span out towards the lateral surface, and the septals, they move towards the septum as the LAD emerges. So we have these 4 scenarios which we will look at in the next 5 minutes. We have a block almost in 40% of the patients before the septum, and what I am calling as the proximal LAD block. We have a block distal, what I am calling as the distal LAD block, which will obviously carry a better prognosis. And we have this after the first septal before the diagonal. I'm not going to bother you with this because this is really going to be complicated. So let's focus on these 3 issues. We have a block before S1, we have a block between S1 and D1, and we have a block beyond S1, D1, the first septal and the diagonal, which will be of course the distal LAD. Now we are talking of ST segment axis. We are not talking of the QRS axis that we always talk of. We are talking of ST segment. Now if the basal part of the septum is involved, you can realize that the ST segment with the electrical impulses will be upwards, and the ST segment will be pointing towards the base, towards the upper side. If the block is distal to the septal and it is before the first diagonal, the axis will be of the ST segment will be pointing laterally, because that's the part which has got involved. The septum is spared. If the block is distal to the first septal and the first diagonal, then the basal part of the distal part of the septum is involved. So you have these 3 scenarios, and as the axis is moving, of the ST segment is moving here, you will have changes in these kind of beats. Here you will not have changes in these kind of beats, you will have changes in these kind of beats, the inferior beats, because the ST axis here is going to point downwards. The block is distal. So what you will have, if you have a proximal LAD block, you will have dominance of the basal area. If you have a distal LAD block, you will have dominance of the inferior or the apical area. And if you have a block before the D1, you will have a lateral area. So this much we have realized by till now, looking at where the block is. And so what changes is it going to make in the electrocardiogram? So just look at this. If you have a proximal block, of course it's an anterior infarct. It's a patient who has ST elevation in B1, B2, B3, B4. But along with that, what we have is changes, ST changes going up in this area. So you will have, of course, ST elevation in B1 to B4, but you will have lead 1 and AVL also showing ST elevation. And you will have AVR also showing ST elevation. And the AV, of course, since it is pointing more upwards and towards the left, you will have AVL more than AVR. AVL is going to show you more elevation than AVR. There will be ST depression in 2, 3 AVF because these are inferior leads and these are leads away from, so these are going to be showing ST segment depression in 2, 3 AVF, and often very importantly in V5 also, because V5 is pointing away from the side in which the V5 is going to be somewhere here. So the ST axis is pointing upwards. So V5 is also going to show you a ST depression. Now something what we used to call as reciprocal changes, which sometimes initially people thought these are changes because of ischemia at a distance. Actually these are changes because of the electrical activities that we have just discussed. So what you will have in a proximal LAD block is you will have ST elevation in AVL, AVR, and you will have ST depression in 2, 3 AVL. So this is what defines a proximal block. So to summarize, if there is a complete right bundle branch block with anterior wall infarct, it's a bad prognosis, it's a proximal LAD block. If you have ST elevation is V1 of more than 2.5, so you have an anterior, the ST axis is pointing anteriorly, so you have ST elevation of more than 2.5 millimeter in an anterior lead V1, this is a bad prognosis because it's a proximal LAD. That's the second important criteria. If there is ST elevation in lead AVR, that's the third. As I showed you axis, the AVR points upwards. So you have changes in these leads. The ST axis is pointing upwards. Then of course, if there is ST depression, as I showed you in 2-3 AVF, because 2-3 AVF are basal leads and the axis is pointing upwards, of course that is going to be the concomitant finding, ST depression in it. So these are parameters which are going to tell you that you have a proximal LAD block. And these are 95 to 100% specific. They are not so sensitive, but they are more specific. So any one of these, if they are there, they will tell you that you are dealing with a proximal LAD block. If you just, I don't want to bother you too much with this particular busy slide, but just see the sensitivity of all these signs. Be it ST elevation in AVR, 95% specific. Sensitivity is not too much. ST AVR more than 1 millimeter, 52% specific. So you are not going to have a high sensitivity of these parameters, but the specificity, the positive predictive value is very high. So if you have any of these features, ST elevation in V1 of more than 2.5, ST elevation in AVR, ST depression in V, just imagine basal inferior leads showing ST depression because ST axis is moving upwards and the upper leads showing you ST elevation. If you just remember this particular fact, you can derive all these things. So if you look at this CCD, what you have here is, anybody would like to take a take?
Anterior wall.
Yeah, it's an anterior infarct. It's an infarct which is not so old since the ST is still looking up. There are changes in the QRS complexes which have come, and there is a right bundle branch block. And since there is a right bundle branch block, this is a proximal LAD block. So there is a marked aspect. Anybody wants to take a dig at this?
ST elevation in AVR.
ST elevation, excellent. ST elevation in AVR and in V1 also.
More than 2.5.
Now later I want to tell you, if ST elevation in AVR is more than V1 or more than AVR, you are dealing with a left main disease. But if ST is elevated in V1, ST is elevated in AVR, but ST in V1 is more than 2.5 millimeter, but not so much in AVR, you are dealing with a proximal LAD. So this is a patient who has a very acute proximal, and you can see there is ST depression in 2-3 AVF. The basal leads are showing ST depression because the axis is going. V5 is showing ST depression. So it's a proximal LAD because the basal leads are showing ST depression, the superior leads are showing you ST elevation. So what you have here, you can just by this very important parameter, otherwise this ECG doesn't look that dangerous to you. It looks rather kind of innocuous. I would not say innocuous, but not so bad an ECG of a patient who's going to have a bad prognosis. So, and this is the electrocardiogram of this, sorry, the angio, sorry, it's not moving. Anyway, I think we can skip here. Yeah. Okay. This is another ECG now. Again, if you notice here, the STs are up. They are not hooking up. It's a little bit. See, one of the most important things that we all look at ECG is to see whether it is few minutes old, few hours old, or it's more than 10 hours. And as the resident rings you up and tells you STs are still elevated, but the Q waves have formed, then you ask him how long is the pain. Because in the back of your mind, it is whether I'm going to thrombolize this patient or not. Is reperfusion therapy a viable probability in this patient, or has this patient come in? So you're looking at ST segments, you're looking at Q waves, whether they have formed, but that's not what Dr. Soni wanted me to speak on. But that is, I would say, a more important aspect in your mind, whether your patient has come within 6 to 12 hours, which is the window for thrombolysis, or whether the patient has come after 12 hours, when the window is already lost. Now let's look at when the block is proximal to D1. Now here the axis is going to be pointing, or the ST is going to be pointing laterally. So you're not going to have ST elevation in AVR, you're not going to have ST elevation in so much ST elevation in AVL, but in lateral leads V4, V5, V6 you will have ST elevation. So you can have an ST depression, of course, since Since it's lateral, it's not going down, you will still have ST depression in 2-3 AVF, that's the inferior leads, but you have typically Q waves in lateral leads, and you have a Q in AVF, since it is pointing towards AVF, which will have a very high specificity. Now, if you look at this ECG, it depicts to you ST elevation. There is no ST elevation in lead V1, there is no ST elevation in AVR, so you can almost diagnose that this axis is moving laterally. The ST axis is moving laterally. It's not going upward. So we are not having in the upper leads in lead V1, in lead AVR, we are not having ST elevation, which are most sinister bad prognostic signs in the patient. But you may have, of course, ST elevation in V1, V2, V3. That's why you diagnose it as an anterior wall infarct. But what we have is a lateral upward axis of the ST segment. Now, if it is distal, if the block is beyond S1 and beyond V1, beyond the first diagonal, what will it show? Now, the axis of the ST segment is pointing downwards. So, you are not going to have ST depression in lead 2-3 AVF here. Now, look at the CCT. It's an anterior wall infarct. It has ST elevation in the anterior leads, but you are not having any ST depression in inferior leads. So, lack of ST depression in inferior leads, look at it. We normally in anterior infarct, we just ignore the inferior leads. But lack of ST depression in inferior leads is a parameter characteristic abnormal Q waves and absence of inferior ST depression in inferior lead. So that's going to tell you that the axis of the ST is pointing downwards and you are not dealing with the patient. Now look at the CCT. You have ST elevation, it's an anterior infarct, but there is no ST depression, no ST elevation in V1, no ST elevation in AVR. So you are dealing with an infarct, probably it's a mid-LAD, or I had this actually picture for you just to make it representative. Anyhow. So to summarize, if you have ST elevation V1, V2, V3, you are dealing with an anterior infarct. If the ST segment is elevated in V1 or your patient has right bundle branch block, you are dealing with a proximal LAD with a specificity of almost 100%. If there is ST segment depression in 2-3 AVF, but those 4 parameters which I suggested are lacking, you are dealing with a block which is between S1 and diagonal 1, and of course there will be ST depression. If you have none of these, you don't have any of those proximal LAD parameters and there is no ST depression in inferior leads, you are dealing with a distal LAD. These patients are going to do fairly well, they are going to go into heart failure, and you can and should thrombolize these patients very comfortably. So this is just a repetition, I don't want to bother you, my time is less. Then look at this, not only in Q wave infarct, in non-Q infarcts also, you can diagnose where the block is. And this is the valence syndrome T wave. What they say is 75% of the patient in V2, V3, if there is deeply inverted T waves, it will localize the block in the LAD. If it's a biphasic kind of thing, it happens in about 25% of patients. If the lesion is more proximal in LAD, the T wave changes will be more widely spread. So if you are having T wave changes in V2, V3 only, you are dealing with a block which is a kind of a mid LAD, but if they are more diffuse, you are dealing with a proximal non-STEMI picture that you have. This is an electrocardiogram of the same type that we have. Now let's come to the inferior wall infarcts. Now inferior infarcts can happen because of RCA block, they can happen because of the circumflex block. So you are concerned because circumflex block patients have more often mitral regurgitations, they have lateral wall, they have ST depression in multiple leads, they can be missed also and they carry a bad prognosis. Within the right coronary artery, it's very important for us to know whether we are dealing with the RV infarct or not, and whether we are dealing with a proximal RCA block or whether we are dealing with a lateral block. So if the block is in the right coronary artery, the axis is going to point towards the base. The ST axis is going to point towards the base. If the block is in the circumflex, you know it supplies primarily, the axis is going to point towards the lateral aspect. 1 AVL, B5, B6 areas. So if there is an RCA block, the axis is going to point downwards, and we know lead 3 is the inferior and the rightward lead. So whenever ST elevation is more in lead 3 than in lead 2, you are dealing with a RCA block. If the ST elevation is more in lead 2 than in lead 3, you are dealing with a lateral, because lead 2 is more towards the left. Both are inferior leads, one is more towards the left, one is more towards the right. So if you have lead 3 elevation more than lead 2, you are dealing with an RCA block. If you have lead 2 elevation more than lead 3, you are dealing with a circumflex block. Presence of reciprocal changes. Now there are going to be because the axis is shifting, ST axis is towards down and towards the right, so there will be reciprocal changes, or you can say there will be ST depression. People have taken so much time in the conversation. I don't think you are.
Yes.
And I am from the host city, so I can take it. Dr. Sobi is a personal friend, that's the third reason I can take it. Okay, I won't take too much time, I will just try to run it. Now, it's very important for us to diagnose right ventricular myocardial infarction. And ST elevation in V1 and V4 are if they are there, then you are dealing with a right ventricular infarction. On this side, if the circumflex area, I'll just summarize by saying you'll have signs of lateral infarct. ST elevation in one AVL, you'll have ST depression in one AVL. So 3 more than 2 ST depression in lateral leads, right coronary block. 2 more than 3 ST elevation in lateral leads, you have a circumflex block. Now if you look at the CCD, let's see, and if you want to just take a, you look at lead 3, look at lead 2, and you look at lead 1 and AVL. So there is ST depression in 1 and AVL, it's pointing towards rightward, and lead 3 is more than lead 2, so you're pretty sure that it's a right coronary block. And in fact, in this case, it's a large infarct, and it must be a wraparound kind of a right coronary artery, which is a hyperdominant right coronary. Because in B7, B6, 7 they have reported, and there is ST elevation in those leads also. Same thing has been depicted here pictorially. Proximal RCA block, ST elevation in lead 3 more than 2, and you have ST depression in lead 1 and AVL. Even the QRS, if the S wave is more than R wave by more than 3, it is a right block. If it is less, it is a circumflex block. This is an additional parameter which you can use. Now if you look at this particular, you have 2 more than 3, you have lateral leads showing changes, so this you can diagnose it's a circumflex block. Now V3R, V4R leads are important, and for diagnosis of RV infarct. Yeah? That's another one. I'm going to finish in 2-3 minutes. Now, if you have upright T wave and ST elevation, you are dealing with a proximal RCA block. If you only have upright T wave but the ST is not elevated, you are dealing with a distal RCA block. So look at the V3R. If there is upright T and there is ST elevation, it's a proximal RCA, it's a RV infarct. If it's only T wave upright, no ST elevation, it's a distal RCA block. These are some things I think we can skip here. And so to summarize, if we have ST elevation in 3, this is something what I just said. There is one more important thing I would like to say before we end. Yeah. Right ventricular infarcts, these changes do not persist. They last for about 8 to 10 hours only. So have it in mind, and V3R must be recorded in all patients with inferior infarcts, because you treat patients of RV infarct differently. You give them lots of fluids, you avoid nitrates, you don't depend so much upon inotropes, but you depend more upon fluid therapy in these patients. And this particular ECG lead has a sensitivity and a specificity of close to 80% for diagnosis of RV infarction. So just simple V3R if you look at. These things we've seen. Another important parameter, if you don't have V3R, V4R, and you still want to make a guess whether your patient, the combination of ST elevation in V1, more greater elevation in V1, and ST depression in V2, it's highly specific of right ventricular infarct. So before you have a V3R, if you have just this, you can diagnose RV infarct. Posterior infarcts are missed very often. They should be diagnosed. They are at times diagnosed by taking lateral leads. And the 4 parameters for posterior infarct are in V1, if you have tall R wave, if you have horizontal ST segment depression, if you have upright T waves and a dominant R, this is what will diagnose an infarct, and this is what the ECG shows. I think we rushed to it last time. So left main blocks are if there is ST elevation in AVR, which is more than E1, this has a sensitivity and a specificity pretty high. So look at AVR lead whenever you are dealing with anterior infarct. Something, if I have to give you one simple take-home message. And these are some of the parameters which tell you how to diagnose left main disease. If you have, anybody wants to just spend half a minute on this? What does this show? It shows ST elevation in V1, but AVR is showing even greater ST elevation, and you have significant ST depression in multiple leads, lead 1, AVL, V4 to V6. So it's a left main equivalent. Either it's a proximal LAD, proximal circ disease, triple vessel disease, or it's a left main myocardial infarction. Same thing, just to impress upon in your mind, AVR showing ST elevation more than in V1, diffuse ST changes, and of course. So friends, I would conclude here by making just a couple of comments. Distinguish infarct from pseudo-infarct pattern, which could be there in early depolarization patients with pericarditis, patients with hypertrophic cardiomyopathy, patients with gross left ventricular hypertrophy. Just spend a few moments on that. ECG interpretation, of course, should always be done correlating with symptoms, that is chest pain. Routinely, ECG is used for looking at duration of onset of infarct, since in the back of our mind it is whether I should thrombolize, whether the patient is eligible for that or not. But localization of block within the culprit vessel can help an interventionist to plan primary PCI, and more importantly, a physician to prognosticate their patients as to where the block is and what we are going to find. Anterior infarcts can be localized as proximal, mid or distal depending upon direction of the ST vector. This has important prognostic implications. Right bundle branch block, ST elevation in V1 more than 2.5 millimeter, ST elevation in AVR and ST depression in V5. These are some parameters which tells you are dealing with anterior infarct. Anterior infarcts with ST depression, look at the lead 2-3 AVF also, because you are dealing with a more proximal kind of a block there. Amongst those with inferior infarct, I'm sorry, this is like greater ST elevation in 3 more than 2 and ST depression in AVF indicates a right coronary artery block. And ST elevation in 2 more than 3, lack of ST depression in AVL, and presence of ST depression in V1, V2, V3. This indicates a circumflex block. It is a rather longish actually topic, so I'm sorry. And I would in fact like to end here by saying have bedside echocardiography, because echo is, you should have echo in the emergency room, because it's going to tell you about complications of acute MI, it's going to tell you about the size of infarct, so many more, or what is the fluid status. If you look at the inferior vena cava, you look at the IRV, you will know how much fluid you can administer. So echo is another important gadget in your armamentarium which will help you manage your patients of acute myocardial infarction better. Thank you.